Good evening, folks. Welcome to you all here in the Barnet. It's not a bad turnout for our humble little group, and for those online as well. Apologies from Mariana this evening. She has a family bereavement. So it's our pleasure to welcome Jean-Claude back for a second session this year.
Correct, yes.
We had poliomyelitis early in the year. We've had all sorts from Jean-Claude over the years. Art, ancient Egypt, military, orthopedics. Yes. So as you see, leprosy this evening. So I imagine this is going to be a little more than our sort of Monty Python experiences with, as I see in one of your slides, things don't necessarily fall off. So I'll leave it up to Jean-Claude now. Thank you very much.
Thank you, Chris, for your introduction. And good evening, everybody, those here and those online. Now, leprosy is not a disease you would normally associate with New Zealand, but my interest in this topic is twofold. First of all, I have training and experience in tropical medicine, having worked on the African continent for 5 years. And second, the fact that leprosy actually has orthopedic manifestations, sometimes leading to mainly hand surgery, and I'm a retired orthopedic surgeon. Now, by chance, I came across this book on the left there called The Colony by John Tayman. And it really describes quite a big colony on Molokai Island in Hawaii. And he tells a harrowing story of leprosy sufferers who were exiled forcefully on this island. And it functioned as a leprosy quarantine station for over 100 years. Now, then this book led me to another book, which was retracing the history of leprosy in New Zealand. So the New Zealand equivalent of this book by Tayman, and on a much smaller scale, but similarly soul-destroying. And this is a book called The Dark Island by Benjamin Kingsbury, which relates the story of the leper colony in New Zealand on Quail Island. So here's the outline of my talk. I will take you through the history of leprosy. I talk about the discovery of its bacterial origin, a little bit about epidemiology and transmission, how is leprosy transmitted, and that was for quite a long time, people had the wrong ideas regarding the transmission of the disease. I go over the clinical manifestations, the treatment, and then I will focus on leprosy in New Zealand. First of all, now what's the origin of the term leprosy? Now, as always in medicine, most of the time the medical terms come from the Greek, and comes from the Greek word lepra, which means a disease that makes the skin scaly. And of course, there are lots of dermatological conditions, skin conditions, which make the skin scaly, like, for example, eczema or psoriasis. And that was as one of the difficulties of interpreting the old text. You never know, is it really leprosy or they're talking about some other dermatological condition? Leprosy is one of the oldest disease recorded. Together with tuberculosis, has been around a long time, bubonic plague, sort of smallpox, malaria, those sort of ancient diseases affecting the human mankind for thousands of years. And this is, it's clear that leprosy has been around for over 4,000 years. And this is evidenced by text and excavations, mainly from India. It is also mentioned in the Ebers papyrus, going back to 1550 BC. And it's mentioned 68 times in the Bible, actually, in the Old and also in the New Testament, under the term of zarath, which again is a sort of a broad term for a number of skin diseases. Now, if you look at Leviticus, it actually outlines the ceremonial laws for individuals with leprosy. So according to the Bible, the lepers had to wear torn clothes, they had to have unkempt hair, they had to cover their upper lip, and we will see later on what the reason for that was. They had to warn others by crying, unclean, unclean, and live in isolated outside the camp. In the Ebus papyrus, leprosy is called ukedu, which basically translates to a condition, a skin condition with pus formation and with tumors. But the paper published in the International Journal of Leprosy in 1935, which I've mentioned here, disputes this, saying that ukedu, again, is a general pathological concept of a number of conditions which can cause pus, skin conditions which can cause pus and swellings. But this author points to the surgical section of the papyrus, which describes actually two cases of skin discoloration and mutilations, which definitely are cases of leprosy. Well, there are many stories about leprosy in the Bible, and this is one. This is in 2 Kings 5. This is Naaman, who was a commander of the army of Aram, and he had leprosy. Now, he was told to go to Israel to see the prophet Elisha, who had been healing people affected with that condition. So Naaman was told that he should bathe 7 times in the River Jordan, which he did, and he was miraculously cured of his leprosy. And then is the story of Lazarus, the leper. You see here the leper with all the ulcers over his whole body. This is in Luke 16. And the terms Lazar actually means leprosy hospital, and Lazaret is a quarantine station. Comes from this the story of Lazarus, the diseased and crippled beggar. And Lazarus is also the patron saint of leprosy sufferers. Now, a little bit about the origin of leprosy. Well, it's felt that it was first found in East Africa and the Middle East, and from there it spread along the trade routes. It was very common in the Middle Ages in Europe, and I read that there were 19,000 leprosy hospitals functioning by the year 1200. Sounds quite a lot to me. People suffering from leprosy were stigmatized, and it was viewed in those days as resulting from a divine punishment or a curse. As a result, sufferers were isolated and forced to warn others, like calling out unclean, unclean, or using a bell. Now, here's a map of the distribution of leprosy in the late 1800s. So you can see there's a high prevalence across tropical countries. You can see here a lot in India, Southeast Asia, Africa, South America, mainly Brazil, going up to middle Central America and a little bit in the southern United States. And you can see there's one outlying country. At the top there is Norway. And this explains the next part of the leprosy story. Leprosy was discovered, the bacillus responsible for the condition was discovered by this person, Hansen, and therefore leprosy is also called Hansen's disease. He was a Norwegian physician. Obviously, they had a lot of cases there, so they had a lot of clinical material. They did some research, and he discovered the bacterial origin of leprosy in 1873 in Bergen, in Norway. He disproved the hereditary origin of leprosy and established that it was a communicable disease, an infectious disease. He actually observed the bacillus, which are small rods in unstained tissues from leprosy patients. And this bacillus is very similar to the bacillus which caused tuberculosis, which was later discovered in 1882 by Robert Koch. Now, Hansen gave some tissue samples to a German physician, Albert Neisser, and he successfully stained the bacteria and identified them as Mycobacterium leprae in 1879. Now, this effectively, so it's the first bacteria identified as causing a human disease. Now, Hansen worked in St. George's Leprosy Hospital in Bergen. The central photo shows you the hospital, which is now a leprosy museum. On the left and right are some drawings from the time of Hansen's work. On the left, showing the typical hand and toe deformities. And on the right is a patient who has a facial nerve palsy with the abnormal shape of his mouth. Now, Mycobacterium leprae develops and replicates inside cells, so it's intracellular in humans. But there is also an animal reservoir. There are two animals who are affected by this bacillus. One is the nine-banded armadillo, which you find in South America, Central America, and a little bit in the south of the United States. And the other one, interestingly, is the red squirrel, who also carries a leprosy bacillus. So you can actually get leprosy by eating armadillo, and some people, you know, in the past have eaten armadillo. So it's not a problem. There are no armadillos here in New Zealand, so you are unlikely to get it. So the only way to culture the bacillus is in the foot pads of mice. But in the human, in patients, the bacillus is normally isolated through a split skin smear. So you incise the lobe of the ear and then take a smear, or you have to take a biopsy and do a histopathological examination to identify the bacillus in the tissues. There's a lepromin test available, which is similar to the tuberculin test, which you do in tests for tuberculosis. And then there are some blood tests available, and they are based on serology and PCR. Now, a little bit about epidemiology. Now, it is an infectious disease, so it can transmit it from an infected person to a non-infected person, but it has a low contagious potential. So you really need to be exposed to the bacillus for a long period of time. So, and it has to be in close contact with somebody who's shedding the bacillus. And it's transmitted through aerosol droplets, just like COVID, basically. And it enters the body mainly through the mucosae, the lining of the nasal and respiratory passages. The incubation period is actually very long, on average 5 years. It sometimes takes 5 years before you see the first signs of the disease. And it can vary from a few months to 20 years. So it's something which develops over a long period of time. Now, how common is it? Now, the prevalence worldwide has decreased quite significantly in the last couple of decades. I mean, 20 years ago, there were about 700 to 800,000 cases reported each year, but now the last report in 2024 from the WHO reported 172,000 cases. These are reported cases, but I'm sure that there are some countries where they are not always reported. And 80% of these cases come from tropical countries. And there's a high incidence in countries with a large number of indigenous people. I think this is sort of due to the hereditary, they might have a low problem with their immune system because normally 90% of people actually have immunity against leprosy, what I read. Now, the countries with high numbers include India, Brazil, Ethiopia, Bangladesh, and Indonesia. And there's also a very high burden still a high burden of leprosy in the Pacific Islands. Now, here's a world map with the current distribution. You can see again spread along the tropical countries, Africa, India there, Southeast Asia, and then South America, high incidence in Brazil, and a little bit in the southern part of the United States, as you can see there. Now, the clinical manifestations, I mean, how does that disease affect humans? Well, it affects the skin, the peripheral nerves, and the upper respiratory tract and eyes. So because it affects the nerves, the bacillus affects the nerves, people develop areas of numb patches of skin discoloration and nerve thickening. The nerves thicken up, they swell up. Particularly for the diagnosis, it's behind the elbow, the ulnar nerve, because it's very superficial. It's easy to feel. And behind the knee, where there's the popliteal nerve, which is also superficial, you can feel the swelling of the nerves, and it causes a painful neuritis. And the underlying pathological process is actually a T-cell mediated inflammation. Here's an illustration of the different manifestations of leprosy. So as I said, it causes discolored patches. They're pale, reddish. And the skin over those patches is numb. It can develop ulcers on the plantar aspect of their feet due to the insensitivity. So they don't realize when they injure themselves, and they develop sometimes infected ulcers. Weakness and paralysis because of the nerves are affecting mainly the function of the hands. They affect also the eyes, and they lose their eyebrows, their eyelashes, and sometimes the eyelid becomes paralyzed due to the facial nerve being affected, so they can't close their eyes. So that can affect the cornea and lead to blindness. They have nodules, and of course, vision loss can happen as a result of damage to the cornea, or even direct effect of the bacillus on the optic nerve. There are two types of leprosy. There's a tuberculoid leprosy, where they develop these patches but nothing else, so anesthetic patches, as you see on this photo there. These patients with tuberculoid leprosy, they have a very good, strong immune response, and very few bacilli can be identified. Whereas the other type, the lepromatous leprosy, is where they develop these skin tumors, the skin nodules. They have a weak immune response, and they are multibacillary, and they can also lead those cases, you can get multi-organ involvement, which you do not get in the tuberculoid type of leprosy. A few examples here. So these are two cases of lepromatous leprosy with these skin tumors, nodules here in the face, giving the patient the appearance, giving this leonine faces, leonine face of a lion. These are photos from Norway, going back to 1886. You can develop saddle nose deformity because the bacillus affects the mucosae of the nasal passages and the upper respiratory tract, and then it damages the cartilaginous, the part of the nose, and even the bones of the nose. You get the saddle nose deformity, as you can see here. Nose necrosis. If this is not treated, gradually they can develop a nose necrosis, and you can see this photo on the right, why the Bible said you have to cover up your upper lip. This is quite frightening, and that's why leprosy was quite a frightening disease, because people were scared and afraid, and etc. History of the treatment now. Well, I will look at it under those four topics here. I mean, for a long time there was no treatment, but the basic sort of issue was that isolation. So they wanted to isolate people to prevent the disease from spreading to other individuals. And I talk about that in a second. Then there was some empiric sort of treatment, and then the sulfonamide-based antibiotics, which basically managed to eventually cure the disease. And there's a little bit about surgery. So the mainstay of treatment over many centuries was lifelong quarantine. Lifelong quarantine. Not like COVID, where you go into quarantine for maybe a few months, or this was lifelong. The aim was to prevent the spread of the disease. And this was achieved in different ways. I mean, in some places there were leper colonies, or mainly on quarantine islands. They put them on islands, or segregated wards in hospitals. And segregation was, in many countries, was codified in law, so that if you were suspected of having leprosy, the police, you were arrested and strictly forced to, and taken to one of those colonies. Now, some of those they were taken away from their families. The families would not be able to see them anymore or visit them anymore. And some of the leper colonies, they married amongst themselves and had children. And as soon as the children were born, they were taken away and sort of looked after and adopted out, and these parents would never see their children again. The stigma of leprosy was driving these policies due to the visible changes and also the misunderstood way of how leprosy was transmitted. So all this leprosy issue caused a profound societal fear and mass hysteria and panic. Now, this is Molokai Island. The book, The Colony, refers to that colony. There was a big colony in Hawaii on the island of Molokai. And this map shows you where Molokai is. You can see it. It is close to Maui. And further south, you can see the main island of Hawaii. So this leper settlement was called Kalapapa, and it was situated on Makogai Island on a peninsula located on the northern coast. And this was very, I mean, they put this colony there because the area was very inaccessible. On one side, you had 2,000 feet cliffs, and the rest was the open sea. And the history of this colony is very well documented, and the first patients arrived in 1866. Here you can see some original photos of this colony. You can see the leper houses, little cottages, and you can see the cliffs at the back, and impossible to escape. The colony was supplied with food and used to bring new patients in by boat. And it functioned for over a century. It was a big colony, and over the years, 8,000 leprosy sufferers died on the island. I mean, normally you don't die of the disease, but you die of the consequences. I mean, they were not looked after very well, or they were dying of other conditions. And this included a Belgian priest here, Father Damien. He contracted leprosy whilst living and working in the colony. He was a minister, but he was also a carpenter, and he used to build churches and schools. They had churches, they had schools, they even had a prison there. He and another sister, Marianne Cope, they both were later canonized as saints of the Catholic Church. Okay, so that was the mainstay of the treatment in those days, was quarantine, isolation. And then came a period where people have looked at some sort of traditional remedies, some empiric treatment of leprosy, some traditional remedies like plant extract, oils, and others, and chemicals, including mercury. But they were used, but none of them were really effective. And the side effects were serious. They caused significant pain when they were injected into musclery, or if they were taken orally, they caused severe nausea and vomiting. And basically, it made those people suffer to no avail because it didn't make any difference. Now, this was quite was quite extensively used across the world. It's the extract of the seeds of the Chalmugra tree. I've never seen a Chalmugra tree, but maybe some of you have, and I'm sure some of you know, because it's a tropical tree. You find it in India and other countries. And this was developed by Alice Ball. She was a Black American chemist in 1915. She did some research and felt that this was helping patients affected with leprosy. She completed the master's degrees in chemistry at the University of Hawaii, and that's how she got involved in when she did her research work and got involved in developing this for leprosy. Unfortunately, she died young in 1916, age 24. The cause was unclear, but possible due to chlorine poisoning. Now, this oil you could use it topically to put on the ulcers. You could also take it orally or in an injectable form. However, it caused severe nausea, taking it orally. And the injectable form was not a lot better because the intramuscular injection of this oil caused a local reaction, including abscesses at the injection site. And its effectiveness was never proven. It was used in New Zealand and on Quail Island as well. Now, here's a paper from the London School of Tropical Medicine published in 1921. And this author talks about Chalmugra oil in leprosy and tuberculosis. And he developed a sodium and soluble preparation by isolating the fatty acids from this oil with the aim of reducing the side effects. And the paper concludes and claims successive results. Now, ladies, for the ladies, Makogai oil is sold as a rejuvenator of your skin. So there you go. Another treatment developed by a German physician, George Dicke. Now, he used the bacterial fat extracted from leprosy nodules to stimulate the patient's immunity. It was sort of an early immunotherapy, basically, and it was called Nastin, and Nastin is very close to nasty, isn't it? The trials were carried out between 1909 and 13 and then abandoned because it didn't work, but it was also used in New Zealand. Finally, in the 1940s, the sulfonamide derivative used for TB, Promin and Dapsone, were trialed in leprosy and showed clear improvements. So there was some light at the end of the tunnel eventually. And finally, Dapsone, which was trialed by Robert Cochrane in Madras in injectable form. Unfortunately, it had similar side effects as the previous compounds, particularly anemia. And John Lau in Nigeria used an oral form of Dapsone with good results after 6 months of treatment. So that was the mainstay of treatment from the 1940s onwards, and it was used as a monotherapy, so one drug. And this resulted in the Mycobacterium leprae to develop resistance. By the 60s and 70s, it didn't work anymore in not all cases, because some patients had developed resistance. Just like antibiotics these days, you know, you often have to use more than one because of the development of resistance. So currently, multi-drug treatment using rifampicin, Dapsone, and clofazimine for 6 to 12 months is the recommended regime by the World Health Organization. Now, it seems that the outcome in tuberculous leprosy is better than in lepromatous leprosy, probably due to the fact that patients with tuberculous leprosy have a better immunity response. Vaccines, are there any vaccines available? No, there are no vaccines commercially available, but there's one company who's working on one. The BCG vaccination, which is given for tuberculosis, can be used in contacts and in high-risk patients, but it doesn't cure leprosy. Surgery can be used in advanced cases to deal with the consequence of nerve involvement, particularly causing muscle weakness and wasting. So here are some orthopedic manifestations, like patients can develop ulcers in the sole of their feet, which can become infected. They cause osteomyelitis. Paralysis of the ulnar nerve can cause clawing of the fingers, and you can see wasting of the small muscles of the hand. They are wasting of the first web space, affecting the function of the hand. And in chronic cases, advanced cases, it can lead to destruction of the joints of the foot, like you can see there. A little bit like in diabetes, because in diabetes, the nerves are involved as well, and then you get these problems with the joints of the foot mainly. Now this Dr. Paul Brand, he was a pioneer of leprosy orthopedic, leprosy orthopedic surgeon. He was British born, and his parents were missionaries in South India. And he was born in South India, actually, and He studied medicine in the UK and then went back to India. And he worked at the Christian Medical College in Vellore in South India. And he understood that the lack of feeling, the pain and insensitivity to pain was the cause of the hand and foot deformities. And he set up a leprosy rehabilitation center in Vellore. He dedicated his life to the care of leprosy sufferers. And he wrote a very good book entitled The Gift of Pain, where he explains how skin insensitivity in leprosy leads to hand and foot deformity. So pain, we always think pain is a bad thing, but actually pain can be a good thing, because if you don't feel pain, then you end up with quite a lot of problems, as those people with leprosy have demonstrated. He wrote a textbook of hand surgery and did quite a lot of research and work on tendon transfers in leprosy. I had the privilege of visiting Vellore on a number of occasions, and they're doing fantastic work there with those patients. Now, here's a list of operations which can be done in late leprosy once it's, you know, the main emphasis should be early diagnosis and drug treatment. But in some countries, it's not available, or they present late, and then they have these claw deformities of the hand, the fingers, the foot drop, and they can be corrected. If it's early, they can be corrected by tendon transfers. Of course, if the joint is destroyed, you have to stiffen the joint, do a joint fusion. Orthopedic surgeons are involved in ulcer management. Sometimes you have to amputate toes for underlying chronic osteomyelitis. They have chronic ulcers, and then it gets to the bone, and then the ulcer won't heal. Nerve decompressions. And here on that photo, you see what's called mitten hands. You know, the fingers have dropped off, and they can't use their hands anymore. For the ophthalmologists, they do surgery to allow the eyelid closure due to leg ophthalmos. These patients develop the inability to close their eyes due to paralysis of the facial nerve. And if they can't close their eyes, the cornea will dry out and damage the cornea, and they can end up being blind. And then the plastic surgeon can help with the reconstruction of the nose. So those are the type of surgery you can do. Now, finally, in New Zealand, yes, the history of leprosy in New Zealand is interesting. New Zealand had a small leper colony at the beginning of the 19th century on Quail Island, which is in the Lyttleton Harbour. And it's not a history we can be proud of. Here's Quail Island. You can see it there in the small island situated in Lyttleton Harbour. You can see it there on the map. Now, Quail Island was actually a quarantine station from 1875 onwards, just like our quarantine island here in Otago Harbour. Wellington had one, Soames Island, and there was one in Auckland. Can't remember the name. So this was a quarantine island where migrants coming on ships, if they were sick, if they had scarlet fever or I don't know, smallpox, or they were quarantined there. And they also quarantined animals were quarantined there as well. Now, as a quarantine station, it had a small hospital, which was actually used during the different influenza epidemics to isolate patients. And the leper colony was active between 1906 and 1925. And Quail Island was also used as an animal quarantine. This photo shows the quarantine station with the hospital. It had a hospital, the double-story building in the center of the photo. You can see there, and then to the left, where those pine trees are, you can see some cottages. Now here you can see Robert Falcon Scott and his wife, and they were inspecting the ponies and the sledge dogs before he embarked on his fateful Antarctic expedition. So these animals came from, I think that, I'm not quite sure where the ponies came from. The dogs came from Siberia or something like that. And they had to be quarantined because Falcon Scott left from New Zealand. The ponies were a disaster. They were no good in Antarctica, and most of them died or were eaten by the explorers as they ran out of food. This map shows, this is a map of Quail Island, so you can see that the leper settlement was tucked away on the eastern end of the island, whereas most of the island was actually used by the agricultural department for quarantine of animals. And there was a constant fight between the agricultural department and the health department. Actually, obviously, you can see that the agricultural department was controlling most of the island, and the leper colony was a very small part of it. Now, the leper colony lacked infrastructure and medical nursing facilities. There was no doctor there. There were no nurses there. They were dumped there. They were left without basic care, except a monthly visit from a Lyttleton GP. And I come back to this chap. Now, 14 men were sent there, and 2 died during their stay. The first one was actually he was from Christchurch, Will Wallens. He was a tailor in Christchurch, and he was from Queensland actually, so he had leprosy when he came to New Zealand, and he was hospitalized first in the Bottle Lake Hospital, was with the infectious disease hospital in Christchurch, which subsequently became Burwood Hospital, and then he was the first one taken to Quail Island, and then he was followed by another 13 men. One of them actually managed to escape by walking to Lyttleton at low tide. He changed his name to Freeman, withdrew money from the bank, took a taxi to Christchurch, and then traveled incognito to Lower Hutt, where he lived in a boarding house until he died. Now, the names of the patients, you can see them there. The names of the patients are listed here. And based on those names, you can see that they were mostly Maori and Chinese. The colony actually closed in 1926, and all the residual patients were transferred to Makogai Leprosarium in Fiji, which was quite a big settlement of leprosy sufferers. Here are some photos of the individuals there on the left standing. The wooden huts where they lived, and this is the community hall, but there was no functioning hospital for the lepers on Quail Island. There are 2 more photos here, the leper cottages. Some of them are still there. They still exist, and you can visit them on a Quail Island tour. Some of them are preserved. Now, this man here is Dr. Charles Upham. I think he was a saint, having looked after these men single-handedly for over 20 years. He was a GP in Lyttleton and went over once a month to visit those 12 men. Now, he's the uncle of a more famous Charles Upham. There's another Charles Upham, who is quite famous. He was the World War II double Victoria Cross recipient. This shows Dr. Upham here with one of his dogs called Billy. Here are some statistics of leprosy cases seen in New Zealand between 2003 and 2014. There were a total of 38 cases. They were reported mainly from the North Island. There was only one case in the South Island. Interestingly, the ethnicity is recorded as Pacific Islands in 60% of cases and Asian in 30% of the cases. There were very few Pākehās, very few. So the Quail Island settlement closed in 1926, and all residual patients were transferred to Makogai in Fiji. This was a big leprosarium. It looked after 4,500 cases over the years, and it was run by the missionary sisters of the Society of Mary and was closed in the 1960s. And that's where the New Zealand leprosy patients were sent when Quail Island closed. They were much better organized. The patients were much happier. They also felt that the food was better. So they were looked after much, much better than on Quail Island, where they weren't looked after at all, actually. And New Zealand had an officiate of these sisters in Upper Hutt, and they were referred as leper sisters. So they were trained there before going to Fiji to look after the leprosy patients. And this is an article out of the local paper published in 1959. Now in Otago, leprosy was mainly associated with the Chinese gold mining community. There were a few isolated cases which unfortunately ended up living in inhumane conditions, completely isolated and abandoned by the New Zealand health system. And there was one leper, a Chinese, Kong Li, or Lai. He was working at Round Hill as a gold miner. And there was one who lived, that was in 1884. There was one in 1901 who lived at Murphy's Flat, and his name was Hui Shing Tsok. He was isolated in a hut at McRae's Flat, East Otago, died in 1907. The locals refused to bury him. They basically burned his cottage with him inside, and then buried an empty casket, basically. The only ones really advocating for these poor souls were some of the local church ministers. And Reverend Alexander Don was one such person. He was a Presbyterian minister who worked as a missionary to the Chinese gold mining community. He fought against, there was quite a lot of discrimination against the Chinese because hundreds turned up during the gold rush, and the local population sort of weren't happy. And there was some discrimination, and this chap, Alexander Don, debunked what was called xenophobic leprosy. They were basically saying all these Chinese gold miners have leprosy, but he advocated for them. He proved actually to the local authorities in Alexandra, this guy here, Yang Tsung, was a market gardener, and he was accused of having leprosy. But Alexander Don proved that he did not have leprosy. And here are the photos. Here's his face. There's no sign of leprosy there. The only thing is he has a small shortened thumb on the left side, which was not due to leprosy, but was due to the fact that he had an infection of that finger, maybe as a young man or as a child. So he had no leprosy. And this is a newspaper clipping about a Portuguese leper living in St. Clair in 1890. You can see there what the sad death has mercifully put an end to the Portuguese leper at St. Clair. A week ago, it was considered that he would probably not last long, and in view of this, the Reverend Father Lynch visited him at short intervals with the view of affording spiritual consolation. Wellington also had their local leper, Kim Lee, a greengrocer, also Chinese. He was arrested on the suspicion that he had leprosy and initially quarantined on Soames Island, which is the quarantine island in Wellington Harbour. Now, the locals did not like having a leper on that island, and then they transferred him on a small, very, very small island at rowing distance from Soames Island, and he lived there in a cave, and the lighthouse keeper used to row out there every day taking him food. But of course, if the sea was rough, he couldn't do that, and the poor leper was left without food. He died after 1 year. Now, what about why? There's a history of leprosy in Maoris. Well, there is evidence that leprosy actually existed in Maoris in pre-colonial times. Here's an article by an American American from the University of Southern California, and he is referring to gerengeri as the Maori term for leprosy. And so possibly, it was possibly introduced into New Zealand by walkers during the migration from Polynesia, because there was quite a lot of leprosy over there, and it was probably introduced that way. So what is the current situation of leprosy in New Zealand? Well, on average, there are 3 or 4 cases reported per year, mostly imported from the Pacific Islands and Southeast Asia. So they're mostly migrants from those areas. I remember looking after one person from India when I was working here at Dunedin Hospital. He had leprosy, and I saw him with problems of his toes. So there are a few cases. I asked the question, how much do New Zealand doctors know about leprosy? I mean, there were a few cases, yes. Our medical students taught about this disease. I found 2 review articles published in 2015, one by the infectious disease specialist in Christchurch, Stephen Chambers, and that's what's published in 2015 by the Journal of the New Zealand Medical Association. There are quite a number of charitable organizations looking after leprosy patients and their families, including in New Zealand. And the Pacific Leprosy Mission was actually founded by a New Zealander, this chap here called Patrick Toomey. He sort of raised almost $1 million for this charity. He was born in Wellington, and he was known as the Leper Man. And of course, the late Brian McMahon, which he was a past chairman of the board. Brian used to travel to Fiji and the Pacific Islands in his role as chairman of the Leprosy Mission. There's a website. If you are interested in their work, you can look it up, or you could even consider making a donation. So there we go. So this is the history of leprosy, and a fascinating disease. Not so much for the patient, but to understand how this all came about. So it's a very ancient disease, as I've indicated. It's certainly disfiguring if it's not treated early. It affects the nerves and the skin. And the stigma attached to disease has been a huge problem over the centuries. The cause was unknown for a long time until Hansen discovered Mycobacterium leprae. Current quarantine and isolation was the mainstay of treatment before the advent of sulfone antibiotics. New Zealand had a small leprosy colony on Quail Island. Leprosy has not been eradicated, although there is an effective treatment, a treatment which works, which can cure leprosy, is available, but there's still quite a number of cases around the world, and I've outlined that in my talk. And currently there are 3 or 4 cases reported in New Zealand, mainly in migrants from endemic countries. I finish with a quote from Mother Teresa. The biggest disease today is not leprosy or tuberculosis, but rather the feeling of being unwanted. So thank you very much for listening to me. I'm happy to take questions if you have any. Thank you. I give the microphone back to our chairperson.
Thank you very much, Jean-Claude. Yes, if we have questions from the audience, I'll hand the microphone around. Hopefully that is now going. And for those online, either put something into the chat or feel free to unmute yourself. I've now set that for you to be able to do. So any questions in the house for the moment?
Yeah, thank you. That was brilliant. Thank you very, very much. Hey, I had a question though. Most of the people you mentioned were male names.
Yeah.
Is this extraordinary? Is that...
Yeah, it's an interesting observation. Yes, they were all male, but I think females get leprosy as well. So I think it was just a lack of the draw, I think, because it was a small number. If you had thousands of them, you would certainly have females as well, women as well. Yeah, they were all male. Good observation. Thank you.
Oh, hello, what a fantastic talk. But I was reading this year that the drug thalidomide that was taken in the 60s by pregnant women and caused terrible fetal abnormalities, if it's given to the male person with leprosy, can almost cure it. What are your thoughts? Have you heard of that?
No, I haven't come across this, Peter, but it's a possibility. I will have to look that up. It hasn't come across my research, but thanks for your comment on that. If anybody else maybe has got the answer, please feel free to put your hand up.
Just you're talking about the incubation period being 5 years or even longer, but does that imply that the person wouldn't even know they have leprosy and that they'd be passing it on unknowingly, like adding to the people they're living with, for example, or their families?
That's right, yeah. The incubation is basically the period of time before you get the symptoms of the disease. So it is, yeah, I mean, they then shed the bacillus and infect other people. But the contact, you have to be in contact, not just sort of briefly one day, you have to be basically living with that person to contract it, okay? Or like in a family, I mean, your wife would contract it or children or something like that.
Do you mean you're contagious before you have symptoms?
Yeah, that's correct, yes.
Yes, that's quite nasty, isn't it?
We used to see quite a few of these cases, and it was, one thing was clear, there are areas where there is overcrowding of people and very poor people. It used to be quite common in those parts of the city. In our clinic, we used to have a leprosy clinic. The people coming there were mostly from that part. The rich people never used to get it, or people who are got a lot of space around their houses. Overcrowding was one of the problems. I don't know anything about now. Left India 50 years ago.
Yeah, I think overcrowding, poverty is related to leprosy. And of course, overcrowding gets you into close contact with other people. Whereas if you live in a city, affluent, if you're more affluent, you don't have that overcrowding, so less risk of getting it. But India still has got, I mean, currently still got cases of leprosy. So why that is, I don't know, because treatment should be available in India. It's that maybe they not accessing the treatment, maybe still that stigma of leprosy, which prevents them from accessing healthcare. So there was a question there, no? No? You okay? No.
Thank you. I had the opportunity of working on 3 occasions at a hospital in Thailand, which had been set up as a leprosy hospital. In fact, the first case that I dealt with when I went for my first stint there was an amputation for somebody who developed a squamous carcinoma and a chronic ulcer, leprosy. But they had still a number of people working or living in the hospital who had burnt out leprosy and who were doing a lot of craft work. I also remember on one occasion a young man who had been diagnosed with leprosy and was put onto Dapsone, another medication, and this caused darkening of skin pigmentation. So in fact, he was ostracized by the family, and because of the skin color, until he'd completed the treatment, and then color had returned to normal, and he could then come back into the family. And one other thing, in 72, when I was going through from New Zealand to Glasgow for a postgraduate work, I stopped off in Boston, and I had the privilege of hearing Paul Brand speak at Massachusetts General Hospital. He was working at that stage in a leprosarium in Louisiana, but he talked also of the deformities which occurred and the problems with diabetic neuropathy, as you've mentioned there, and so it was a very interesting catching up. Thank you.
Okay. Yeah, I think he worked in Quail, Louisiana was a big leprosarium, yeah. In South, yeah. All right. Yeah.
Dealt with, and shall I repeat that? In a modern society where we don't isolate people, how is the contagion dealt with if there's no effective vaccine? I think you said 50%.
So you're asking about the role of isolation currently? Yeah, but you don't isolate them. You don't isolate them anymore. Okay. So once they're diagnosed, you treat them basically with multi-drug treatment. Because if they're in the incubation period, they have no signs. You don't know. They don't know that they've got leprosy. So once you develop signs or they identify somebody with leprosy, then they will also look at the contacts. But you don't isolate them anymore.
Just following on from that, is there any contact tracing? And for how long would you do that? With a blood test, or would you just wait for the contacts to develop symptoms?
Well, no, there are blood tests available now. There are serology, PCR tests available.
So close contacts, do they get screened for 20 years for like TB contacts?
That's a good question. I don't know. Yeah, I don't think they are screened or for that long. I don't think. The emphasis is on treating the person which is infectious. And if you treat them within 7 days, they're not shedding the bacilla anymore. So it's pretty quick. And then the contacts, of course, if they are negative, that's it. You're negative. I think that's what's happening, but I'm not sure. Yeah. Thalidomide is used to treat type 2 leprosy reactions. Peter, somebody says here. As a child, I remember that my Catholic mother always kept envelopes for donation to the leper man when I lived in the Pacific, I saw a number of dispensaries erected by the Leprosy Trust. Thanks for that comment. What date were diagnostic tests standard? I understand Kim Lee was not offered these in 1903, despite them being common. Could the symptoms be a result of his opium use and malnutrition instead? He died after 7 months on the tiny island. The lighthouse keeper put food in a flying fox when he couldn't row out. Well, in 1903, I mean, biopsies were available. Could take a biopsy of the skin or the lesions and then stain it and look up under the microscope. Was probably the only thing available at that stage. The symptoms be the result of opium use and malnutrition. Well, opium use, I don't know, but malnutrition, poverty is related to leprosy is related to poverty and malnutrition. Opium use, I don't know. Probably for pain. Maybe they were using it for pain relief. Okay.
Well, if there's no more questions, nothing else has come up online.
Oh yes, can I tell you about the case I diagnosed in Dunedin in the 80s? I'm at home. Was that David Crook?
Yeah.
Yes, David.
Yeah, I was. Can you hear me?
Yes.
Yes, thanks.
Okay. I was working at the Cadbury's Industrial Health Clinic once a week in those days, and a bloke came along, or perhaps one of the nurses there brought him through to the clinic, and he had what they thought was a ringworm. It was quite a large area on the chest with a ring around it, and asking him about it and getting the history, it sounded like a case of leprosy. And he was an islander, and in those days, Cadbury's would employ islanders as well as disabled or partly disabled people. It was a benevolent organisation then. And anyway, I referred him to the dermatologist, but I had to put on my letter not leprosy, which might have caused a bit of a upset to people. I called it possible Hansen's disease, and he got seen and treated, and that was the last I saw of him. So yes, it can be seen here.
Thank you, David, for that comment. All right, okay, I think we will conclude, and thank you for coming, and have a good evening.
Thank you very much, John.